continue. Let's continue. The people who are the group of population who are more susceptible to have tuberculosis is going to be Asian population. Second, you can have Hispanic population, African American population. So those are the highest groups of incidence, number of new cases in a year in United States of tuberculosis. The lowest, one of the lowest in the world is going to be United States. But why we study tuberculosis in United States? Because there is two sources of tuberculosis. One of these is people who born outside United States and came here. They can develop tuberculosis, high risk. Other people who can develop tuberculosis, and remember that, and there are some changes on the pharmacology we will see today, is about HIV. People who have HIV have more risk to have actually tuberculosis. How many cases of tuberculosis we have every year in United States? In United States, we have about 9,000 new cases of tuberculosis every single year. And the regimen of treatment will be between 6 months to 2 years, up to 2 years. Okay? So 1 year treatment is when you have one system affected, for example, the lungs. But if you have beyond the lungs other systems, you can go treatment up to 2 years. Okay, so we will elaborate that in a few moments. Let's see, Novelani, any contribution? Let's put it that way.
No.
And you, Hillary?
I remember that tuberculosis is caused by mycobacterium it's caused by mycobacterium tuberculosis, right?
Mycobacterium, yes.
Bacterium.
Tuberculosum. Yeah.
Yeah, and it's you can either do a skin test, right? Skin test, or do an X-ray.
PPD, right?
PPD or X-ray.
Tuberculin is the same to PPD? Or is it different?
Oh. What was that?
Tuberculin.
Tuberculin?
You heard about tuberculin? Okay, yeah. Perfect. So, yeah, see, I want just to see where we are and where we are going to end. Excellent, Hillary. Excellent. So I can see there are some terms, oh, Melissa, I didn't ask you. Any contribution, any addition, or anything that probably you found interesting or not, or
can't you have it without showing any symptoms? But then if you don't have symptoms, you can't pass it, right?
Yeah. Tuberculosis have a rate, death rate or mortality about 7% of the cases. 7 to 10% of the cases can lead into death. And the tuberculosis can last few years, up to 20, 30 years. So it's a chronic disease. It's a chronic disease, a very chronic. All right, so let's start. So just to make it shape, let's start talking about the nursing process, right? So how we start the nursing process?
Assessment, patient history.
Patient history, assessment, yes. Patient history, and patient history. How you divide that? How you divide your clinical history? Besides, you tell me the objective and subjective. So objectives and subjective can be in these components. What could be the components that you need to have in your mind in order to have a clinical history?
Family history.
Sorry?
The patient's family history.
That is the third. So you start that is one of, from the history, that is one of the latest that you are going to add. But before that,
Past, present, and the family history.
sorry, Ann.
Past history, and then the present, and then family.
Yes. So that is what you're going to do: present, past, and family history. Present, past, and family history. I know I said that many times in the past. I think I'm going to hammer in your mind about that. And my last, I would say, my last shot will be to try to hypnotize everybody, just to remember the present, the past, and the family history. Okay, I don't need to hypnotize, right? I don't know how to hypnotize, by the way, with a clock. No? Okay. So we are going to talk about the present, past, and the family history. Again, when I'm going to tell you, when you're going to, basically, there is a clinical history, when you're going to do clinical history in admission, right? And that's it? That's it? No, right? You need to do all the nursing process each time you are seeing the patient. And the clinical history, present, past, and family history are going to be not as in detail that you had in the admission. During the admission, they have a very detailed assessment, very detailed. But if the patient is already in the hospital, is already being hospitalized, and you visit the patient to administer the drugs, you don't need to do the whole scene. You need to do the same structure, but in making priorities to focalize on what you are talking about. Okay? So, for example, in this case, I will go the assessment of patient with tuberculosis. Will be assessment, the clinical history, the present. How are you going to check the present? Present. What is the main complaint? How are you feeling today? That is the beginning. How are you feeling today? You don't say, are you coughing? Are you bleeding? No, you're not saying anything. You need to ask the patient in the way that the patient will tell you. Because if you give answers to the patient will say yes, yes, yes all the time. And that is going to create huge bias, because it's going to be you go to the doctor and the doctor is telling you that, and you telling the patient told you this, and when the doctor is coming, the doctor is asking the patient the same question and saying, no, I didn't say that. All right, so you need to be very careful on that. Very careful, very careful. All right, so this patient is in a clinical setting, or probably is at home, because mostly of the patients with tuberculosis are not hospitalized. Mostly of the patients are going to be outpatients. They are going to be at home. Thank you, Melissa. And that is, but every time, even though the patient is at home and you're going to administer the medication, you need to assess the patient following the nursing process. So, in other words, nursing process are everywhere. Every time you're getting close to the patients to administer medication or just to assess the patient, you need to follow your nursing process. Okay? In this case, we are going to see patients who are going to be in the hospital. Why the patient can be hospitalized? It's not that common to see patients with tuberculosis hospitalized, only when they are having some complications. Okay? So you're going to start talking about the clinical history, the present, the past, family history. Probably in this case, I'm talking about the setting that the patient is an inpatient, is already in the hospital. You don't need to do to family history already, because that is already in the clinical history in the admission. You okay with that? You got me? All right. So then, after you doing that, the clinical history, basically, if the patient is having treatment, you need to assess as a baseline what the patient was feeling in the previous days. So that is your past history when the patient is an inpatient. Okay. Now, what is next?
Labs.
Labs. Everybody got that? Laboratory tests. Laboratory tests. Which laboratory test will be appropriate for this in this case? So imagine a patient is in the hospital. Imagine the patient that you are at home. It's a patient who is at home receiving medication, right? So which laboratory tests you would like to hear or to keep in your mind?
CBC.
All right, CBC. What else? Related to blood tests, okay. What about the sputum? The sputum is important, right? Why is it important, sputum? Sputum is to be if the patient if the tell me if the sputum is negative and the patient have 3 months taking anti-tuberculosis medication. So the patient means that this cure? No, right? Of course not. Yes, they're not going to be cured. So you need to follow the regimen of treatment. They can be from 6 months up to 1 year when it's one organ or one system affected. You can go up to 2 years if there is multiple systems, 2 or more. But the patient is going to control if the patient if the disease is active. If the disease is active, means that the patient is still contagious. Okay, what else? You would like to see is there some X-rays or PPDs, tuberculin. So everything related to what really it is tuberculosis. Okay, if the patient is having problems with the lungs, basically you need to have respiratory functional tests like FEV, like a forced expiratory volume, or for example, saturation of oxygen. Those are laboratory tests. All right, so then after laboratory tests, so you said, okay, the patient, you can conclude the patient, the latest lab test was that day. Oh, okay. So this is too old lab tests, so probably we need to request a new lab test. See what I mean? So that is going to help you to be on the top of the situation. So not always think about the laboratory test. Even for 1 second, think about the laboratory test. For 1 second. But you need to get used to think about the laboratory test in whatever situation. Because that is going to actually basically affect the patient, right? So some other drugs that you need to know the therapeutic level. So they need to request some laboratory tests. Okay. So after that, we have the clinical history, the laboratory tests, and then what we are going to do. No, miss. Why you text me? Everybody texts me. Why you don't talk to me? You like to text better than tell me some? No? Because when you text me, when I go to the lecture, I'm not able to see it. Who is texting? Okay, so what is next? Come on, let's go.
Vital signs.
Vital signs. The vital signs. Vital signs. You don't do the physical exam without having vital signs first. You need to do your vital signs. Your vital signs and make note. Then after what? After the vital signs, then you're going to make the focal assessment of the patient. Thank you, Nordan. So focal assessment of the patient. Okay? All right, and the focal assessment depends on where is the problem. The most common, obviously, will be the lungs, right? The lungs. The lungs are going to be basically one of the most common areas that is going to be affected by the bacteria. Why? Why lungs? Okay, so we will see that now. All right, so let's start with tuberculosis, and remember your nursing process, please. Okay. Okay. All right, so here we have the lungs. I should put some normal tissue of the lung. Basically, I will tell you, yes, this is a normal tissue here, this area. This is a specimen, of course, right? So this is not a picture of a live person. So this is already they already took the lungs out. So these black, can you see these black areas?
Yes.
That is a smoke. That is basically cigarettes, smoking. So that is the deposit of charcoal that are located in the lungs when the patient is smoking. Here we have in this area is very hyperemic area. So there is some bleeding here. So we are going to see it later. But this is normal tissue. Normal tissue. Now look at this. Can you see that? This is the lung. Put your hand on the top and feel the granules, the small elevations. So those are actually basically areas that are going to be the mycobacterium tuberculosis. It's not only one. In each nodule, you will see that there are millions of bacteria, but they put together a nodule here. Why is a nodule? Look at this. If you have a bacteria here, I'm going to put in yellow just to give an idea here. It is green. Okay, this is the bacteria. The bacteria is very tricky bacteria. Why? Because when somebody is trying to kill the bacteria is going to get into the cell to hide. So antibiotics are not going to be able to destroy a normal cell. So when the tuberculosis is getting into the cell, they're going to sleep. They're going to stay without doing anything. They're in dormant state until the antibiotic or foreign or agent are going to be away. So now, what happened with this? With this bacteria, when it's established in that area, so what happened is going to come macrophages. So what happened when the body cannot get rid of the bacteria? The body, what it's trying to do is to isolate. When you cannot destroy the enemy, you need to isolate the enemy to minimize damage. Make sense or not? These isolate nodules, these nodules of macrophages surrounding bacteria are these. All these granules you see there. Can you see that?
Yes.
Okay, perfect. All right, so let's start talking about tuberculosis. Number one, we have tuberculosis. What means tuber? Tuber means cavity or tunnel. I will take tunnel, funnel, a cavity, a space. It's like a drilling. So this mycobacterial tuberculosum, what they're going to do is to drill, is basically to perforate, to make cavities, tunnels. So that's why it's called tuber, because tuber means in Latin tunnel. Okay? Tuberculosis. Tuberculosis means that the bacteria is going to destroy tissue and make cavities. So now, for this, it's very important to remember this. So we have a lung here. This is the trachea here, the trachea. And the tuberculosis could be, basically they like mostly on the bases, but they can start reach because they make some damage, making tunnels. Some of the vessels are going to be ruptured, start bleeding. And some of the bronchi can be perforated too, because the bronchi is a tissue and the mycobacteria, they like bronchi too. So the blood starts to float into the bronchial tree. and the blood is going to accumulate, reaching the carina, reaching the trachea. You start to cough, and produce what we call the hemoptysis. We okay with that?
Yes.
Yes.
Hemoptysis. Okay. One thing you need to remember: the reflex cough reflex, that is clinical. Cough reflex is going to be diminished, or not present when something is below the trachea. When something is below the trachea, that is when you start to have fluid there, but the cough reflex is not going to happen. The cough reflex is when something is in your trachea. So you're coughing. You can tell that there is something in the trachea. You can assume that still something below that is coming. But the one who, when you don't have cough, after that, you cannot rule out that there is fluid or substance in the bronchi. For that, you need to assess the ventilation and the oxygenation of the patient. So again, the cough reflex is going to be from the throat down to the trachea. So if you have a repetitive cough, means that at least something is in the trachea. At least something is in the trachea. But if you don't have cough, I will mean, if you are coughing, and you suddenly stop coughing, this is getting better? Not necessary, because that flame or sputum is not located in the trachea, but it's still forming below that. And when it's below that, do not produce actually a cough reflex. So for that, you have other tools: the auscultation, the oxygenation, the ventilation. So those are your tools, clinical assessment. Okay? We okay with that?
Yes.
Okay. So the tuberculosis mycobacterium tuberculosum is basically is not stained by gram positive or gram negative. Okay, so we are going to be the test for check the presence of the mycobacterium is going to be the acid fast smear. Question for RDMS? No, for NCLEX, sorry. Every 2 to 4 weeks. Every 2 to 4 weeks. So every month you need to have a sputum test. Sputum. Did somebody told you how to take a sputum already?
Not yet.
Okay, I will tell you. Tell me, I'm going to produce an sputum. And I spit out. That is a
No.
sputum? No, that
No.
is not a sputum.
You
You
need a
need
deep
to
cough.
exactly. You need to feel that the patient need to feel that the mucus is coming from below, from inside, from the trachea, from the bronchi, like that, and they are going to become a mucus. Otherwise, you are going to be saliva, and just making a fast smear test with saliva by sure is going to be negative. So you need to have a sputum, and the sputum is characterized by mucus. Okay? If there is liquid, fluid, clear, that basically is saliva. So you're not doing anything there, anything good. Okay? All right, so tuberculosis is the bacteria is called the Mycobacterium tuberculosum. Mycobacterium. That is the name. We have type tuberculosum. Tuberculosum, the second name is with lowercase in general. Tuberculosum. Another one, we have the Mycobacterium murium, and the other one is the avium. So there is different type of mycobacterium. The most common will be the tuberculosum. For patients with HIV, mostly what we see is the avium. Avium means bird, so it's kind of participate in the cycle where the bacteria is living, the birds. Murium means the cattle, the cows, whatever. Tuberculosum is more general. Okay? Okay. Tuberculosis. Tuberculosis is one of the oldest diseases in the world. There are actually some studies that they say that tuberculosis is with us since 20,000 years ago. 20,000 years ago is a lot. Okay? All right, so mycobacterium tuberculosis. Now, the other thing I want you to remember about this is that mycobacterium tuberculosis, number one, they love the lungs. They love lungs. Number two, they love kidneys. Number three, they go liver and the rest. They can be bones too. Can be invading the skin, can invade the meninges and the brain. So Mycobacterium tuberculosum making cavities in any of these tissues. But why is lungs number one? Lungs number one because mycobacterium, they love oxygen. Oxygen. Kidney is too. They receive 25% of the cardiac output. So that's why there is very rich on oxygen, means rich in what? In oxygen, correct? You follow me?
Yes.
Okay, so is the mycobacterium tuberculosum are going to affect the lungs as making cavities. Think about making cavities. It's like a minery. They are going to make cavities. They can produce some rupture of the vessels. They can reach one of the bronchi, and this blood flooding the bronchial tree, and they can produce coughing with blood. That is called hemoptysis. We okay with that?
Yes.
Yes.
Tell me, what could be based on that same description or idea, what could happen with the kidneys? If the tuberculosis is in the kidneys.
Could it rupture?
Okay, and what happened?
Kidney failure?
Failure?
Before that? Signs and symptoms.
Back pain?
Uh-huh. Okay, so based on the same rationale that we was talking about the lungs, the mycobacterium tuberculosum, when they reach the kidney, they can destroy some vessels, and these vessels bleeding, the mycobacterium can destroy through some convolute tubules, or proximal, distal, or Henry loop, whatever, making bleeding getting into the convolute tubules. And what happened? You have hematuria. That bleeding coming from patient with tuberculosis is because the destruction of mycobacterium reach one of the vessels, one of the collecting ducts, and the blood is draining through the kidneys. Make sense or not?
Doctor G, I have a question.
Yeah.
I thought the brain has more oxygen than the kidneys.
Kidneys, the brain is going to be about 20 to 35%. Yes, it can be the brain. So, but brain and kidneys are going to be a very much high cardiac output, brain and kidney. But probably because we have the BBB, is helping the brain not to get the mycobacterium tuberculosum. BBB is the brain blood barrier, right? Remember that?
Yes.
Yes.
Right, the kidney doesn't have any barrier compared to the so the brain is more protect than the kidneys. Okay, probably could be that is the reason. But yes, you are right. The brain is having 25 to 30%, even 40% sometimes of the needs of requirement of oxygen. Okay.
Yes.
Yes.
Okay. All right. So next. This mycobacterium, and this is English, very important. Mycobacterium are going to be tricky bacteria. So they get into the cell in order to prevent to be killed by the medication you're giving to the patient. So this mycobacterium, when it's a tricky enemy, very tricky enemy, if you kill with one weapon only, the bacteria will develop some way to block that way of being killed or to kill the bacteria. So that's why we use treatment about 6 different medications. Basically, we start with 4 medications and then 2 medications, but we are going to use a combination of drugs to to kill the bacteria in different ways, in different manner, in order to prevent that the bacteria can produce some resistance to the medication. You okay with that?
Yes.
So that's why we are going to give multiple drugs to treat this tuberculosis. And what is important for this at this moment is you to know that patient education, that is part of your interventions, patient education, is to educate the patient about the adherence of the medication. The adherence of the medication. What means adherence of medication is the patient need to follow the orders how to take the medication every single day. Because if you don't take the medication one day, probably more, you give a chance to the bacteria to react and produce resistance to those antibiotics. Okay, so one of the main beams from the treatment of the patient is the adherence to the patient. If that is not going to happen, the medication is not going to be effective. The patient is have resistance to the drug, and the tuberculosis can spread out to other systems, making more complicated. Okay.
Yes.
Okay.
Okay. So we already have many nursing considerations. Prevent disease in persons exposed to aerobic bacteria. So prevent. So what does it mean? So prevent or cure. So you can cure tuberculosis, yes. But what means prevention? Prevention is going to be related to if you having exposure in the past with tuberculosis. That doesn't mean that you have tuberculosis. You don't, but that means that there's a small dose of bacteria was in contact with you, and the body was reacting and destroying this few number of bacteria, and you create antibodies. So antibodies will be present in your body. Now, if you have an excess of those, most likely the body immune defense is not going to be able to destroy all of them, and you start to develop disease, tuberculosis. Okay? All right. So for this, you need to remember this is NCLEX, very much so, please. LFTs studies need to be about every 2 weeks. LFTs. Why LFTs? You see, kidneys and liver, right? Why? Because this drug can be hepatotoxic. Are going to be hepatotoxic, can be nephrotoxic. So you need to check the liver and the kidneys. So the liver is number one affected. So you every 2 weeks is the standard that we use for laboratory tests. So how much the liver is being destroyed in order to adjust the dose or not. Renal profile. Renal profile is about Chem7. Chem7, you need to have a lab test about once a month. So you need to check for urine color, jaundice. So my wife taught me how to say jaundice. And this jaundice is because why jaundice? Somebody tell me?
Is it because if there's if it's hepatotoxic or
Exactly, because it's
hepatotoxic, yeah.
because it's hepatotoxic. If you have too much damage of the liver, what are the functions of the liver? I ask you to remember the A, B, C, and D or no? A, B, C, D, right? A, well, give me the A, everybody, please. Give me the A.
Albumin,
Albumin.
Albumin.
If you have low albumin, what happened?
edema,
Edema. Why? Because proteins attract water, and the absence of protein are not going to attract water. We are talking in the vascular space, and the water start to escape. Edemas. B. What is B? Give me the B.
Bilirubin.
No.
bile,
Bile.
Bile.
Bile. Bile is the name of liver is the bartender. Remember the bartender? So go to the
Yes.
bartender and ask, bartender, please give me bile. Okay, bile, perfect. So we're going to combine. I'm going to combine lecithin, cholesterol, water, electrolytes, cholesterol, bile acids, bilirubin. So all these components is a bile. Then when the bartender is ready, they are going to put it in the gallbladder. The gallbladder will be the glass. Let's put it that way. The glass where you put the bile. So the bile B of the liver is the liver produce bile, and producing bile related to bilirubin. 120 days cemetery, the spleen, the red blood cells blow up and release the 24,000 molecules of hemoglobin per red blood cell, and the hemoglobin in the blood turn into bilirubin. And what is doing the bilirubin then? They are going to be attached to a protein transporter going to the liver. So the liver is the one who captures the bilirubin. If your liver have hepatotoxicity, are not going to accomplish the goals that it's supposed to be. And bilirubin cannot be captured by the liver. Bilirubin start to accumulate in the bloodstream and produce jaundice. Got it?
Yep.
Okay, so this is at least 3, 4 times we're reviewing that. So right now you need to know very well the B of the liver is the bile, and that you can start elaborate with that bilirubin. C is the coagulation factors. D is the detoxification. Correct?
Yes.
yeah,
Okay.
Yes.
So now, no alcohol. All this is high yield for NCLEX. No alcohol. Why? Because they disturb or block the metabolism of the drugs, of these drugs. So mostly what happens is you can reach toxic levels. So no alcohol at all, please. Okay? Treatment minimum is going to be between 12 to 124 months. No, be careful with that. It's not 124 months. 124 months is like 10 years. No, of course not. It's going to be 24 months. So it's going to be between 6 months up to 2 months. Why I say 6 months? Because 6 months is basically the prophylaxis. So that means patients who do not have the disease but have contact and they have a PPD reactive on the skin. The skin test positive. So these patients do not have tuberculosis, but they give a prophylaxis for 6 months. So, for example, you go to the clinicals, or you go to work, or you go into another school, to a school or whatever, and they said you're actually PPD is positive, without signs and symptoms, and without X-ray negative, with an negative X-ray. That means that you do not have tuberculosis. But in order to be sure that you're not going to develop, you're going to receive one medication for 6 months. If you are having, on the other hand, you are diagnosed with tuberculosis, the treatment will be about 1 year. 1 year. And you already know from the previous lecture that even though you feel better and you feel that you don't have anything, you need to complete the whole regimen of treatment. 1 year. If there is more than one system, lungs and kidney, or lungs or bones, or lungs or something else, somewhere else, the treatment basically can be prolonged up to 2 years. You okay with that?
Yes.
Yes.
Okay. Take
All
at the,
information.
sorry. Take meds at the same time every single day is the best, because you know the fluctuation of the half lifetime pharmacokinetics. If you go up and down, up and down, up and down, so you're going to be excreted at a certain moment. It's better to have at the same day to prevent extreme fluctuations of the therapeutic range of the drug in blood. I'm talking too difficult, or you want me to use easy words? Tell me, tell me. Hello? Hello?
I think it's okay.
It's okay? You following me?
For the most part, yes.
Yeah. Yeah. You notice I'm trying to use a little bit more elaborate technical words, right? Okay. So let's start. All right. So 3 negative culture in 3 different days is not longer infectious. So can I stop the medication? So
No.
No.
no, right? You need to complete the whole regimen of the treatment. So 3 cultures of sputum, we're talking, right? In 3 different days is the patient means that is not the patient is not longer infectious. Infectious. Okay? Okay, that?
Yes.
Yeah. Yes.
All right, so this is our guy, mycobacterium tuberculosum. Let's start giving. Okay. Okay. I put a map here, and you see here that even though that we have like in Pakistan, Indonesia is 200 times more in proportion to the population in United States. But in United States, the rate of tuberculosis are being diminishing. Was like the maximum in 2019, no, 17 was about 9,000. Now is in the lowest 8,000. So I've been decreasing with the time. But you can tell that in every place you go, work, facility, whatever, always they are asking you for a test for tuberculosis. Correct? Right? Okay.
Yes.
Yes.
So right now we have like 8,000 cases every year in United States, and the majority, guess what? Who has more cases of what tuberculosis? The number one is Alaska, but very close to is the what? Is the California? It's California. California, we have about 25% of all, 1/4 of all cases in United States of tuberculosis are in California. Other group that are going to be higher is Hawaii. Hawaii. Remember, Asian population has some higher risk to have this problem. Okay?
Okay.
Okay.
Yes.
All right, so you need to check the effectiveness of the medication. The signs and symptoms are going to decrease with X-ray, negative X-ray and sputum cultures. So what you're going to see in the X-ray, this is actually kind of artistic one, the X-ray that you see here. So it's not really one that I would like to show, but we have in the X-ray, they're going to show some nodules. Where are these nodules? These guys. That's what I show you. That is what they're going to see in X-ray, like small nodules are going to be like a dark areas. So the macrophages surrounding the bacteria to isolate, they are going to calcify. They're going to get deposit of calcium. So calcium is going to absorb the X-ray. So in the image, what you see is a dark area. Okay, because the X-ray need to pass the person to burn the film behind. So when they burn the film behind, that is going to be actually a different, is going to be a gray scale. So I'm not going to explain that right now. Okay, so latent TB, we have latent TB is isoniazide, the INH. INH with rifampin or just the pyrazinamide. So latent means that the patient is not showing signs and symptoms, no showing is not being having nodules, but they have a latent. So that means that the patient can develop, probably, we don't know, maybe yes, maybe not. So for that, you need to do the prophylaxis, latent, tell me, prophylaxis. Prophylaxis basically is going to be isoniazide, or isoniazide with rifampin, or isoniazide with a pyrazinamide, PC. So you will get you're going to get familiar with the names in a few moments. Okay? All right, so we have the BCG. The BCG is the vaccine. Is the Bacillus calmette-guerin. Okay? All right, so that is, if you have, for example, the BCG vaccine, and what is happening is that you can have a positive in the PPD. So BCG is the injection that you receive here in your arm. Okay? This vaccine is, the purpose is to protect your body, creating antibodies. Follow me, please. BCG is going to create antibodies to protect your body. You okay with that?
Yes.
And the PPD on the arm, the skin test, is to identify if you have those antibodies. Make sense?
Yeah.
So
Okay. Oh, sorry?
they would have like a false positive and would need an X-ray.
Yeah, X-ray will be negative.
I have
Skin,
that.
you have that situation? Yeah. So
Yeah.
probably myself, I've been treating patient tuberculosis many years ago. I have a very good pool of antibody for tuberculosis, for sure. But do I have tuberculosis? No. Do you have tuberculosis? No, you don't have tuberculosis. Okay. All right. So the PPD is called tuberculin. PPD or tuberculin. PPD is the purified protein derivate, the PPD, or it's called the Mantoux tuberculin skin test. Mantoux. You can call Mantoux test, Mantoux tuberculin test, PPD test, or purified protein derivate. See how many names they have the same thing, right? Okay.
Okay.
And now, why is called tuberculin? Why they don't stay with PPD? PPD is the purified protein derivate. So that means that they take one of the proteins that is basically specific or different from other bacteria. They identify that protein, and that small protein they're going to give it to you. And this protein is going to produce a reaction. It's a protein, it's not a bacteria. It's just one protein, so it's not going to create disease. Okay? And it's called tuberculin because the PPD is given through an injection, a syringe called tuberculin. That's why tuberculin and PPD are exactly the same. You okay with that?
Yes.
And the injection is transdermal. What means transdermal? And no NCLEX. Transdermal means between the epidermis and the dermis. Okay, it's not hypodermic. It's not subcutaneous injection. It's transdermal. Okay? Another NCLEX. How soon you're going to read the test? 2 to 3 days,
Is it 72 hours?
48 to 72 hours. We okay with that? And you will see a redness on the skin. So the redness, are you going to measure the whole redness? Yes or no?
Yes.
No. Only you are going to measure the induration, the elevation. The elevation of the skin that is elevated, that is actually what you measure. The redness around is not, you're not going to measure. Otherwise, everybody will be positive for tuberculosis. We measure only just the induration, the induration. So induration means the elevation, the little bumpy area. You don't measure the whole redness. Is that clear or no? Very important.
Yes.
Okay. And the positive is considered when it's 10 equal 10 or more millimeters. So the induration measured should be no more than or should be less than 1 centimeter. So less than 10 millimeters. Okay?
Yes.
Okay. So now you are going to have you're going to find a job, and they're going to take the tuberculin test, skin test, Mantoux test, or PPD, whatever you want, and you're going back in 2 days. They found out that you have a very reactive papule in duration, more than 10 millimeters. So what they're going to do is to take another test. That is the protocol, huh? Another test, or PPD, another PPD. If the PPD is positive at that time, there's two ways. Some people said you have signs and symptoms of tuberculosis. Where you live, where you coming from a different country. Okay? So they're asking all these questions. And if you're asymptomatic, basically they are going to tell you that you don't have the disease, but you have. But the technical way to do it is to take an X-ray. To take an X-ray. In the X-ray, if you are positive, is PPD positive, and with some signs and symptoms, that by sure is a diagnosis already of tuberculosis. So you need to have the whole regimen of the treatment for 1 year. Then they want to find, they're going to do physical assessment to see if there is other areas who are being affected in order to prolong the therapy up to 2 years if that is necessary. Okay, so it's not like a 1 + 1 is 2 or 3 + 3 is 6. No, it's basically depends the situation. What time is it?
12:31.
Oh, okay. So let's continue here with the first line of medication. We have the rifampin, isoniazid, ethambutol, streptomycin, that is a derivative of aminoglucoside. Yes, aminoglucoside. We have the pyrazinamide and the PAS, the para-aminosalicylic acid. So there is different medication. Let's start. I put this guy priest because is the way that I remember, or we can remember the names of the drug. Priest, P, pyrazinamide. You can PC or PCA, either way. R, rifampin. I, isoniazid. E, ethambutol. ST, streptomycin. PAS is not used very common. So priest. What is P? Pyrazinamide. What is R? Rifampin. What is I? Isoniazid. What is E? Ethambutol. What is ST? Streptomycin. Okay?
Okay.
Excellent. All right, so here we have when the patient, they are going to have multiple, so don't move your slides. So I want just to show you something here. Where is the stuff? Okay. This is extra. Okay, so this is basically the regimen that you're going to use for these patients. For example, they are going to start using with drug-sensitive tuberculosis. That means that the tuberculosis is being killed by the bacteria. Otherwise, will be called resistance tuberculosis. No, this is the majority of the cases are not resistant, but there's some resistant strains of bacteria. But this drug-sensitive bacteria, that means that this mycobacterium tuberculosis can be killed by this medication without any resistance. So they are going to use 4 drugs for 2 months and 2 drugs for 4 months. 4 drugs for 2 months, 2 drugs for 4 months. Okay? Okay, so for this, I'm going to start talking about, here. We have the isoniazide, pyrazinamide, ethambutol, and that is rifampin. Look at this, I put it here. In addition, rifampin is contraindicated because they reduce the effect of HIV antiviral drugs if the patient have HIV. Okay, so rifampin will basically decrease the effectiveness of that retroviral medication, and that is very bad. For that, you need to change to rifabutin. Okay, rifabutin. So that is important. All right, so let's start with the pyrazinamide. In the pyrazinamide, please, you need to remember, I'm going to be very simple, okay? Pyrazinamide, priest, is going to, but basically all the anti-tubercular medication can increase the LFTs. You need to check the profile, kidney profile. LFTs every 2 weeks, and kidneys every month. And what is happening with the pyrazinamide is that increase the uric acid levels. Is going to increase the uric acid levels. So this is basically they are going to ask you, please, okay? Increase uric acid levels. They can produce bouts of gout. So a uric acid crystals deposit in the joints. Okay, so polyarthralgias occur in 40% of patients during initial phase of treatment with pyrazinamide and can be managed definitely with NSAIDs, for example, ibuprofen. Okay? Rifampin. The rifampin are going to, I want just you to remember this. These are what basically what they're going to ask you is what I'm going to mark here. Rifampin. Reddish orange secretions. Yes, the urine become red. How to remember that? Rifampin red. Okay, simple to remember. Rifampin red. So the urine become reddish. So you need to have patient education because after taking the rifampin, the patient is going to call you, I'm bleeding, you're killing me, I'm going to sue you, you're very bad, whatever. And what you had to do in the past is just to tell them, you were going to take this drug, your pee is going to be red. So you prepare the patient. Okay, patient education. Not only that, the sweat, the tears, saliva, they can actually tinge with what? With red. Okay? All right, so are going to decrease, and this is another important thing for NCLEX, is from all this, they'd like to ask you basically OCP, oral contraceptive pills. Oral contraceptive pills. Oral contraceptive pills. So oral contraceptive pills are to birth control, right? Medication. And decrease the effect of the OCP. So what you're going to do? If you have tuberculosis, you're taking rifampin, and you are sexual active. So what do you need to do? And you're taking OCP.
Use other methods.
Exactly, use another method. You have one question there that they like to ask. Okay? Hepatotoxicity for all antitubercular medication. Now, the isoniazide. What is P? Everybody P? What is P? Tell me, please.
Pyrazinamide.
Pyrazinamide. Side effect?
Increase uric acid. LFT.
Increase uric acid. The rest, the hepatotoxicity, nephrotoxicity, all that is general for common for all the antitubercular drugs. Now, the revamping, what you need to remember is the secretions are going to be reddish and the OCP are going to be diminishing effectiveness. So that means that you can get pregnant even when you're taking revamping and you're taking OCP. So what you need to do is to change the method. Okay? So P, pyrazinamide, R, the revamping, I, isoniazide. Isoniazide is the INH. You need to be familiar with this shorthand. Isoniazide is the cornerstone of the treatment. Without isoniazide, basically there is no considered treat. We okay with that?
Well, actually, isoniazid is like the key component for
Yeah. The
Okay.
cornerstone means is the from the building which one is the main beams that support the whole structure. That means cornerstone. Cornerstone is the beam of the wall that is supporting the whole house, the most important wall. So that is the isoniazide. Okay?
Yes.
Okay, perfect. So now let's talk about side effects of the isoniazide. Isoniazide, we have peripheral neuritis. That is the same to say peripheral neuropathy. Peripheral neuropathy is like a more broad term. Peripheral neuritis is telling you more specific, a little bit more specific, that is an inflammation of the nerve. Inflammation of the nerve. Okay? So what happened here? Uh, so,
Dr. G,
yes.
is that similar to carpal tunnel? Like the feeling?
Yeah. Peripheral neuritis. You more. The first thing that's very good. The first thing you can detect is that you become more sensitive to pain in certain areas. Numbness, tingling, numbness, tingling, numbness, tingling. So those are when you have a nerve that is being damaged. The first thing that is going to be affected, just in my nerve, including strokes, traumas, whatever. The first thing is the numbness, sensitivity. The second that you lost after that means more serious is the motor activity. You cannot move that area. And the third that is totally already worse is when you lost the reflexes, the reflex of the area. So that's why in clinical, I'm sure they're teaching you where are all the reflexes, cubital, radial, right? Ulnar, so ulnar, radial, and kneecap. We have pedal, right? Bicipital, tricipital. So all these are reflexes that you need to know where to hammer the patient. Okay? If not, just take a note and request that to know. Okay? So to do the reflexes in the body. Okay? Okay? Somebody will do that? Okay. Hopefully. Okay? So peripheral neuritis. Peripheral neuritis is there. We are going to give vitamin B6 for peripheral neuritis. Vitamin B6 is depleted when you have this isoniazide. It's going to be depleted. Just remember, they are going to be in Asian population most commonly, then Latin or Hispanic people, then African American. All right, so here we have one thing that here with isoniazide, you're not eating with cheese, tuna, or foods contain tyramine. They can cause redness, itchiness, sweating, tachycardia, basically like a parasympathetic reaction. So no cheese, isoniazide, no cheese or tuna because containing tyramine. So that can bring redness, itching, flushing. It's like your head, you put it in the oven. You feel like that. Well, I don't know because I never had that, but I can imagine. Okay? Tell me one thing. When we saw tyramine in the past, or we didn't see it? This is the first time you see tyramine?
No, we did. I'm just trying to remember.
Aha, very good. Tell me where, when?
Or Farm One.
Yes. Where?
Yes. I'm trying to think. I can't remember.
Tyramine, no cheese, no wine.
The
Hypertensive
contraindicated
crisis.
like Maui's
Huh?
for like antidepressants or like Maui's.
No. Oh,
No.
yeah, Mao is an antidepressant, but we didn't talk about that yet. We was talking about something else. Hello, come on, come on. Parkinson, Mao inhibitors. Remember? Mao inhibitors, neuroprotector, selegiline, eldepril. First step, no cheese, no wine, because they can produce hypertensive crisis. Yes or no?
Yes.
And remember, we use that nifedipine, that is a calcium channel antagonist or calcium channel blocker. See? Okay. All right. I'm telling you. Okay. I'm telling you. So please review that. Okay. The HESI is 20% of your grade and is coming from Pharmaco 1 to 2. All right. So hepatotoxicity, patient report tingling, numbness, hands, dizziness. The phenytoin is what is an anti-epileptic drug, AED. I'm not going to ask that. But when it's coming, I'm going to go back to this. So ethambutol. Ethambutol, basically what they're doing is visual disturbances and uric acid. Okay, so uric acid. So which one produces increase of uric acid is the pyrazinamide, and the other one is the ethambutol. Ethambutol. You have blurred vision, means optic neuritis, ethambutol, and red-green vision changes. Okay. All right, ethambutol, uric acid, uh, uh, visual disturbances, blur vision, or red-green vision changes. So it's like you cannot see, differentiate green and all that, red. And, so when you go to traffic, you have problems. Oh my God, this is red or this is green. We got it?
Yes.
Okay. Please. So we have the pyrazinamide, uric acid, rifampin, reddish, OCP, isoniazid is going to be neuritis, right? You need to take vitamin B6 is the cornerstone of the treatment. Ethambutol, uric acid elevation, and the changes of vision, right? So visual changes like red and green. Streptomycin is an aminoglucoside, and that is having the same side effect that you already learned in aminoglucosides, gentamicin. It's going to be nephrotoxic and it's going to be ototoxic. Yeah? Remember?
Yeah.
Okay. Rifabutin is prescribed with active mycobacterium avian complex called MAC. In the exam, they're going to ask you MAC. When they say MAC, it's not McDonald, okay? It's MAC, Mycobacterium avian complex. And for this, you're going to use the rifabutin, instead of the rifampin. All right, so this is what we were talking about, the tuberculin. So we use the HIV, use rifabutin instead of rifampin. This is for your med search. So I just put it here. We have standard precautions. PPE is going to for standard precaution. It's going to be you need to use standard precautions, or airborne precautions, or contact precautions, or drip precautions. So you can see here what you're going to use and which examples of each of them is mentioning. And for example, 6 meters. No, it's going to be 6 micrometers.
Dr. J,
Yes. Yes.
when are we gonna use rifabutin instead of propane again?
Oh, when you are going to when the patient is having HIV, and the patient is having tuberculosis, don't use rifampicin.
Okay, that's right. Thank you.
Okay, because otherwise the medication, the antiretroviral medication, is not going to be effective. So for that, they use the rifabutin that they have a kind of different pharmacokinetics and dynamics that is not going to produce that effect. Okay, so you have there the examples I was trying to do this morning just to make it easier. An example, what are the PPE tools that you're going to use. Okay, so that is about tuberculosis. Any question?
Not right now, no.
Tell me, do we have a better, a different, no better, a different idea about tuberculosis now? I think we focus, and I give you exactly what you need. Okay, exactly what you need. So you already know how you can explain people about tuberculosis. Okay, so let's have a break. I'm going to see you at 1 p.m., right? 9, 10, 11, 12, 1. Yeah, so 1 more hour. So the next hour we will talk about what? Cancers. All right, see you then.
Okay.
Thank you.
You want 10 or 15 minutes just to make it a hybrid between what happened today? 15 minutes? Let's make it 15.
Okay. Thank
Okay,
you.
so I will see you at 1:15.
Okay, thank you.
Mhm. Hello, everyone. Thank you, Karen. All right, so let's continue. Thank you, Mia. Your camera's on, please, everybody, and all right, so we are going to talk about cancers. Okay. You see here, you see the new. There's one thing that you need to differentiate here to know the importance about this antineoplastic treatment. So we have the new cancer cases. So this is basically 2008, but I didn't change it because the numbers are slightly higher now because of the population growth, right? The normal, the natural growth of the population. But I will say the ranking of cancers are going to be the same. Okay. Okay, just a moment. Give me a second. Okay. So you will see here the new cancer cases are going to be number one in female breast. It's slightly bigger the number, or higher number of cancer, new cases of breast cancer than prostate cancer. But the number one cancer incidence cases, new cases, are going to be breast and prostate. And the third is going to be for male and female are going to be the second for female will be lung cancer, and the second for male will be lung cancer too. So, but look at this. Now the cancer deaths. The cancer deaths, number one cause is lung cancer. And then is coming breast and prostate cancer. So what is the conclusion that you can have with this slide? Is that lung cancer are much more aggressive than breast and prostate cancer. You okay with that?
Yes.
Okay. Yeah. Just to give you a little bit more broad spectrum about this, in male, number one cancer cases, new cases of cancer is prostate cancer. Okay. Then we have lung cancer, and then colon cancer. Colon cancer. In female, breast cancer, lung cancer, and then colon cancer. So you're going to see people who are suffering from these diseases, right? So statistically, the death is, you can put it on the back of your mind. But just remember, lung cancer is more aggressive. Most of the cases you will see in female is breast cancer, number one, second, lung cancer, and third, you will see colon cancer. Colon cancer is the number three in the rank for male and female. Okay?
Yes.
Okay.
Excellent. So with cancers, we are going to differentiate in these two categories, epithelial and connective. Lymphoma we will talk about a little bit. Epithelial cancers are going to be called adenocarcinomas. Connective tissue cancers are going to be sarcomas. So why is it's important to know this difference? Epithelial cancers basically is coming from, just to give you an idea, it's coming from the embryological layer called endoderm. This endoderm are going to be endoderm and ectoderm. From these two are going to basically coming, all the internal organs are going to be formed. All internal organs. So because they're coming from the same embryological layer, are called adenocarcinomas. 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 Another layer is called the mesoderm. You don't need to know this, but just to let you know why it's coming from. The mesoderm are basically a connective tissue. So all cancers coming from this layer are going to be called sarcomas. Sarcomas. Okay? For example, the liver. The liver you don't call hepatosarcoma. No. You call the hepatocellular adenocarcinoma. The pancreas, that is internal organ. You call the adenocarcinoma of the pancreas, adenocarcinoma of the kidney, adenocarcinoma of whatever internal organ you think about. Okay? Lung cancer is an adenocarcinoma. Now, connective tissue will be muscles and bones. Okay? These actually are going to be called sarcomas. Sarcoma. For example, a cancer of the bone is called osteosarcoma. Okay? Cancer of the muscle, myo means muscle, myosarcoma. You don't call myoadenocarcinoma. You don't call a bone adenocarcinoma. You okay with that? And just to complete the idea is that between adenocarcinomas and sarcomas, much more aggressive are sarcomas. Okay? Okay.
Okay.
Excellent. So now we have the treatment for let's start. The diagnosis of cancer are going to be based on biopsy. Based on biopsy. And I repeat that in the past. So you don't do cancer diagnosis with imaging tools or a laboratory test. No. They can give you the indicator, highly suspicious, that could be a cancer, but the ultimate tool that we use in order to have a definitive diagnosis of the cancer is by biopsy. Okay? Okay. After that, you will ask me again, if you have cancer, why they do the CT scan or MRI? They do these imaging tools. Once you are being diagnosed with the cancer, they want to explore all over your body. They're going to give you a CT scan of all your body, or MRI, basically CT scan, to know which nodules are going to be involved. Which nodules we are talking about? The lymphatic nodes. The lymphatic nodes. You know, cancers are cells who has a mutation. A mutation. This mutation means the alteration of the bases, the A, T, C, G, whatever, right? So they give you a different sequence of a gene. These different sequences of gene that is going to produce normally a protein, this alteration of this sequence produce a different protein that the body cannot recognize on their own. So the body starts to destroy these cells who are, especially, they're fighting, in other words, they're fighting against cancer cells. And when these cancer cells are going to spread out by metastasis through the lymphatic system, the metastasis spreading out of cancer can happen by proximity, by one organ close to another, or by the circulatory blood circulation, or by the lymphatic system. So when these cancer cells are going to pass through the lymphatic fluid, there's three options for cancers to spread out. We use three of them. They are going to spread out and they are going to reach a nodule. The nodule that contains lymphocytes B and lymphocytes T are going to start detecting that it's a stranger. So start to increase, they're multiplying a lot of B and T's, and the lymphatic nodes are going to be enlarged. And that's what we are doing after the diagnosis of cancer. You're going to check CT scan to know how spread out is cancer. So why we need that? We need that because there's different protocols for different stages of cancer. Stage 1, 2, 3. Okay, basically most of the cancers are stage 1, 2, 3. And that means the more it's spread out, the more aggressive is the treatment for using anti-neoplastics. We okay with that?
Yes.
So I give you the whole picture, panoramic picture about cancers in a few minutes, by the way. Okay, so now the treatment for cancers are going to be two types, right? We have surgery to remove of the tumors, right? Radiotherapy, that means radiation. You know, radiation is going to basically destroy the cells, right? Radiation. And we have the chemotherapy. So the topic for today will be the chemotherapy. Okay, so radiotherapy is okay. So before just to start with the chemotherapy, that is the topic today, I want to give you some differentiation that I saw in NCLEX question about radiotherapy and chemotherapy. When you have radiotherapy, before that, yeah, I don't know. I can start different ways. Okay, let's start with the chemotherapy and then we go back to radiotherapy. Chemotherapy means chemicals. All right? Chemicals means drug, medication, right? It can be PO, can be IV. So this chemotherapy are a group of substances that they have a special characteristic. So these substances are not going to be antibiotics, it's just a chemotherapy. We will see the names very soon. The methotrexate, we have irinotecan, etc. And these substances are directed to destroy cells who divide very fast, with cell division very fast. And that is one of the characteristics of the cancer cells. Cancer cells are going to multiply very fast, the majority of them, except the thyroid cancer. Anyhow, so they are going to be very fast cell division. So these substances, chemotherapy, are going to be directing his action over these cells who divide very fast, destroying the cancer cells, diminishing the number of cancer cells in the body. Okay? But what is the problem here? The problem here is that this chemotherapy, these substances, cannot differentiate from abnormal cells like cancer cells who divide very fast and cannot differentiate from other cells who are normal in your body. Other cells who normally are dividing very fast in your body are going to be paying the consequence too. So they are going to be destroyed by this chemotherapy. The question is, which cells in the body are going to reproduce very fast? And knowing that, you will know the side effects of the chemotherapy that we will see in the next slides. So cells who divide very fast normally in our body will be, for example, the hair follicles. Another one, the lining of the intestine. For example, the lining of the kidney, the urinary bladder, and the ureters, etc. So those cells are going to divide very fast. You know, I don't remember the number, but your hair is going to grow about 0.5 millimeters per week. So some people grow faster than others, but the follicles, you know, you cut your hair and in 2 weeks it's already growing up. Yes or no?
Yes.
Right. Another cells who are going to divide faster, very fast, are going to be the red blood cells. The red blood cells are going to multiply every second. They are going to give you 2 new red blood cells. Every second, is going to be 2 million new red blood cells per second. It's very fast division. The platelets are going to be produced. They are not cells, as you know. The platelets are produced. That's why I don't say cell. The platelets are produced 1 million per second. The white cells are going to reproduce 1 million per second. Then the lining of the gastrointestinal system, all the lining, all the cells, all the simple columnar cells of the epithelium of the lining of the intestine are going to be replaced every 3 days. Every 3 days. And you know the long of the GI tract is going to be about 20 feet long. And in 3 days, all these cells are being replaced. And similar is going to be between 3 to 4 days is going to be the lining of the urothelium. So that means the lining of the kidney, the lining of the ureters, the lining of the urinary bladder. So in conclusion, we have different systems who are having very fast cell division, including the respiratory tract, GI tract, urinary tract, hair. What else I miss? That's it, right? So those are and the red bone marrow. So you can tell red bone marrow. So as you can tell, there is no diseases, no different diseases. What is having are different patients. Why I'm trying to mean with that? Mean that you have the same disease, two people have the same disease, but the presentation, signs and symptoms can be variable, depends. And that apply to the side effects too. I will tell you again. If you have chemotherapy, for example, you can have bleeding through the urine because the lining of the urinary system are being destroyed by the chemotherapy. Why? Because chemotherapy, they need to be excreted flushed out by the urinary system, the waste product. So that's why that kidney could be a side effect of chemotherapy. Means bleeding. The first sign is going to be bleeding. We have cystitis, inflammation of the urinary bladder. Same with the gastrointestinal. If you have the cells of the gastrointestinal, in this case, are being affected, you can have diarrhea. If you have, for example, in the respiratory system, you can have fibrosis of the lung, fibrosis of the lung. So that means that the tissue is being replaced by scar tissue, Another thing, the red bone marrow. If the red bone marrow is going to be destroyed, they cannot destroy only they can destroy only the platelets. So you have the hypoproteinemia. So you have low levels of platelets that increase your risk for bleeding. Or they can affect only the white cells. If they affect only the white cells, they are going to decrease the number of white cells, increasing your risk for infections. If that is going to affect just the red blood cells, the erythropoiesis, that can lead into anemia, right? And talking about the red bone marrow could be or red blood cells and white cells. Red blood cells damage and platelets, or the white cells with the platelets, or individually, or a combination of three of them. That depends on the patient. So for that, we need to do the monitoring of the patient when they are receiving chemotherapy. Okay? We got it?
Okay.
Yes.
Okay. Now, let's go back to the radiotherapy. Radiotherapy, and that is one of the questions I saw in NCLEX, is this, that when you receive, in the hair, right? Hair. In the hair, you're going to be, when you receive chemotherapy, your hair is going to fall down, right? Yes or no? Bald.
Yes.
And when the patient is receiving radiotherapy, you become bald too, right?
Yeah.
Okay? NCLEX here. When you lose the hair because of radiotherapy or chemotherapy, when you are actually losing your hair, when you're receiving radiotherapy, your hair most likely will not regrow again. Most likely will not grow again. But
Radiotherapy, Dr. G?
radiotherapy, yes.
Okay.
And when you have chemotherapy, when you lose your hair, most likely your hair is going to regrowth again. And that is what is the nursing diagnosis that I always have problem to remember is the how is the self-image disturbance? Is that name? Self-image
so.
disturbance. Ah,
Yeah,
yeah, I remember finally. Yeah. Self-image disturbance, and that is having some is in the context of psychological problems, right? So I mean, produce psychological traumas. Let's put it that way. And for that, you as a nurse, you need to prepare the patient, explaining what could be the options. In this case, the wigs or whatever. How you call wigs, right? Wig, right?
I, uh,
W
I think it's a disturbed body image.
disturbed body image. Yes, disturbed body image. So that is part of your interventions, huh? Patient education. You okay with that?
Yeah.
Okay. Just to refresh you a little bit here, is that cancer mostly happen with some chronic inflammation that can lead in mutation. So the mutations are going to be caused by inflammatory processes that are chronic. For example, smoking. Smoking, you have toxins, and these substances are going to stay in the lung. They are not going to be dissolved and excreted. They are going to stay for long periods of time, impregnated in your lungs. That can cause a very long-term inflammatory process. When you have inflammatory process, means cells are being destroyed. Remember, I was telling you that. So, and what's supposed to do the tissue? The tissue need to regenerate the cells who are being damaged. And that, if you have one event only inflammation, when the inflammation is gone, the cells stop to multiply because it's already healed. But if you have this factor that produce inflammation on the tissue, they are going to regenerate, regenerate 1 day, 1 month, 1 year, 10 years, 20 years, 30 years. There is a moment that the cell say, well, I'm tired to reproduce. There's a mutation, and the cell forget how to stop or when to stop to reproduce. And the cells start to divide, producing masses, tumors, cancers. Okay, you got it?
Yeah.
Okay. Side effects versus adverse effects. You already know that this sometimes is being interchangeable between side effects and adverse effects. Most commonly, we call side effects in general. So some people, they're going to use both terms. But technically, adverse effects is something that you don't expect. Adverse effect is something that you actually don't want to see. But side effects is basically the most common situation. For example, side effects of chemotherapy will be, for example, the diarrhea, urinary tract bleeding. You can have infections. You have problems of bleeding, problems of anemia. Those are side effects that are expected. But if that is adverse effect, for example, will be the fibrosis of the lung fibrosis. So that means that the lung changed the tissue into connective tissue. That means the connective tissue will not behave never as a lung tissue normal. So you're losing the uh, volume capacities on your breathing. Okay, all right. Side effects are predictable. There no need to be reported based on patient education, right? You have dry mouth, headaches. So those are basically based on the chemotherapy. That's why they tell you to take a lot of fluids, a lot of fluids. When you have a chemotherapy, you need to take a lot of fluids. Adverse effects, not predictable. Okay, bleeding by NSAIDs, you need to be careful with that. Rhabdomyolysis means, remember we talk about, just to refresh you, in statins, right? Rhabdomyolysis, HMCO reductase inhibitor, or statins, the Lipitor, atorvastatin, etc. Most potent antilipemic, right? Deafness, mania. How you pronounce that? Mania.
Dr. G,
Oh yes.
I just wanted to let you know the time check is it's 1:30.
Okay, excellent. Okay. All right, so let's keep going. So thank you. Normal cells that proliferate rapidly: skin, hair, stomach, bone marrow, and gonads. Yes, the gonads. What is gonad? Gonads, you know, is the reproductive organs. They can literally affect the number of spermatozoids or the number of ovules that a patient is having. So they can lead into infertility. All right, so now, because of the gastrointestinal signs and symptoms, you can have actually gastritis, inflammation, gastritis, diarrheas, diarrheas. If you have gastritis, you need to have, for example, a small frequent meals, blunt diet, in a small amount to prevent more nauseous and improve the absorption of the meals. When you have a chemotherapy or radiotherapy, the patient is feeling miserable, literally miserable. And all these signs and symptoms are going to resume in about 2 weeks after the application of the chemotherapy. 2 weeks. So that's why the sessions of chemotherapy, some cancers, they have 1, 2, 3, 4 sessions of consecutive sessions of chemotherapy, and they need to wait at least 2 weeks that they are going to resume the signs or side effects of the chemotherapy given at the beginning. You okay with that? Okay?
Yeah.
Corticoids is being used for some. We don't know exactly the mechanism, but they are going to improve the effectiveness of the chemotherapy. Effectiveness of the chemotherapy. If you have a corticoids, you need to remember your table of 10. One of the most relevant here will be the irritability. Irritability. The patient become very apprehensive. Whatever situation happen, the patient start to cry or get upset, mad, etc. Okay? So when you have chemotherapy, I will tell you something more straightforward. Is that when you have chemotherapy, even a small wind, so you open the door, you're close to the door, open the door, there's a small wind coming, right? So this small wind, you feel like nothing because it's just the door was open, just make some wind there, right? But patient with chemotherapy, that small wind are going to feel like you are in the North Pole. It's ice, totally ice. It's going to be like frozen, and the patient need to you need to be put the patient in environment that is quiet, no too much activities, and no winds, as comfortable as you can. Now, but it's not only that. So, for example, when you eat, you have problems with swallowing, right? You have when you touch the spoon, the spoon is cold, but you feel cold, it's okay, cold, right? But this patient feeling like you have ice in between your fingers, so they cannot stand it. So for that, you need to give food in small amounts, and no spices, no hot, no cold, warm as possible. Okay? Nauseous are going to be the ondansetron. Ondansetron is the therapy that we use for this chemotherapy. All right. Avoid crowds. Why? Because they can have bacteria all around. So if you have chemotherapy, the red bone marrow are going to be affected. So you can have increased risk for infections. Avoid cold, hot, spicy foods. Prepare for hair loss. So here we have the names of the drugs that we are going to talk. Basically, are going to mention for NCLEX purposes. There are going to be these. So you don't need to remember all of these because I'm giving you exactly what I will say 95%. So even more. 1% will be the rest. But there's so many names that I want to give you what is directed to NCLEX, the most likely happen. So we have the 5-FU, that is the 5-fluorouracil. We have the methotrexate. We have the beam-blasting, the irinotecan, topotecan, irinotecan. So antimetabolic, mitotic inhibitors, topoisomerase, anti-enzymatic. So just to make all together, what they're going to do is to stop cell division. Stop cell division. Just to explain you a little bit, anti-metabolic, to have anti-metabolic means that to stop the cell division, you're going to block, for example, the folic acid or the vitamin B12. This folic acid, vitamin B12 are needed for cell division. That is what is going to block by these guys. Mitotic inhibitors is the process, prophase, metaphase, anaphase, telophase. They are going to block some enzymes that are going to stop the cell division. Topoisomerase are going to be those enzymes who are going to block the process of cell division. And anti-enzymatic, so those are similar of these, that are going to block some other enzymes that are going to block the cell division. In conclusion, cell division is going to stop. All right, so let's start. We have the pyrimidine antagonist. You don't need to know that or remember that. I want you to focus here in the 5-FU. FU is 5-fluorouracil. Okay? At bolus, this is all these is our NCLEX. At bolus cause myelosuppression. So the bolus means infusion in few minutes, 20 minutes, half an hour. It's not bolus when you apply in more than 1 hour. Okay, in more than 1 hour. If it continues those GI problems, diarrhea, and the question for NCLEX is the antidote for 5-fluorouracil is the timidine. Put it in your book of antidotes. Book of your antidotes, please. Okay, all right. We have the methotrexate. Methotrexate is a folic acid antagonist, as I mentioned before. Methotrexate is used for other situations like arthritis, but methotrexate can be used as antineoplastic. This methotrexate is literally paralyzing the cell division, the cell. And the methotrexate, please, I want you to write down this, please. Write down. Don't take it ever with aspirin. Never with aspirin. Never aspirin with methotrexate. Aspirin, 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 aspirin. No methotrexate, aspirin. The same when, just to refresh you, ACE inhibitors, ARBs, etc., are not using, we don't use aspirin neither, any NSAID. Methotrexate never used with aspirin. You okay with that? Because that is going to decrease the effectiveness of the they're going to increase the toxicity of the methotrexate. It's going to increase the toxicity of methotrexate. And the antidote, another name for your book of antidotes, coming, open eyes, open ears, is the leucovorin. Leucovorin is the what? Is the antidote for the methotrexate. Okay?
Okay.
Okay. Excellent. So we have side effects. We have nausea and vomiting, methotrexate, stomatitis. Those are sometimes we call aphthas. These are similar as when you bite yourself and there's a white area. Those are actually stomatitis. Oh, there you are. Not use aspirin. Lead to lead or lead? Lead or lead?
Lead.
Lead. Thank you. Lead to methotrexate toxicity. Okay? Worse than other antineoplastic for ulceration, bleeding, and oral mucus, gastrointestinal tract, stomatitis, keyword, methotrexate. Check stools because of bleeding, right? Coffee ground, gums, prolonged menstrual cycle. So they are going to produce risk for bleeding. They can lead, as you already know, all antineoplastic have potentially can produce bone marrow suppression. Bone marrow suppression means suppress the hematopoiesis, means the tree line of these structures, or just suppress only the erythropoiesis, or just the white cells, or just the platelets, or any combination of two or all of together. Okay, whatever combination you can see, you're going to find that. All right, so alopecia. Alopecia means baldness. Alopecia means baldness. So they are going to destroy the follicles that reproduce very fast. Nadir, question for exam, is the lowest blood cells, white cells, platelets, red blood cells, count reach after a course of a chemotherapy or radiotherapy? So let's check the nadir. The nadir is the lowest, is the white cells, the red blood cells, the platelets start to go down, 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 down. And that is going to be about 2 weeks. 2 weeks. Then after that, they start to recover again. Okay? All right, so here we have, as I mentioned, average 2 weeks, right? For white cells, 1 to 2 weeks. Red blood cells, several weeks, 3, 4. Nadir result may count normal levels of 4 weeks. So at 2 weeks, start to recover. At 4 weeks, you start to have normal values. Okay, so forget about the plantar bladder dysesthesia. Okay, I want you to remember the tumor lysis syndrome. The tumor lysis syndrome are going to be basically the tumor lysis, destruction of the cells of the tumor. And what is inside the cell? The most common important cation in the intracellular space, intracellular fluid, is the potassium. What is the most common intracellular anion? The phosphate. Yes or no?
Yes.
We
Yes.
have big amounts of calcium too inside the cell. So when you destroy the cell, what happens? Potassium go out, phosphate go out, calcium go out. So calcium are going to be elevated, phosphate will be elevated in blood, potassium is going to be elevated in blood. Hyperkalemia, hypophosphatemia, hypocalcemia. It's hypocalcemia. I don't have clear about the calcium, so just remember, please, hyperkalemia, hyperphosphatemia, these two. Sorry for that. Okay?
Dr. G, all this still in methotrexate, right?
Yes.
Okay.
Yes. And can lead into hyperuricemia. Hyperuricemia because the cells contain the nucleic acids, destroy the cell membrane, and the nucleic acids are going to be metabolized and produce uric acid. Okay, so uric acid is the byproduct, yes, of the metabolism of the nucleic acids. And that is when you destroy too many cells, that will be that. Okay? Hyperuricemia, you're going to talk about allopurinol. Remember the allopurinol? We talk about allopurinol or no? Hello?
We might have gone over it just a little bit. It sounds familiar.
Okay. All right, so allopurinol is for gout. Allopurinol, colchicine, and probenecid. Probenecid is going to be used for decrease the levels of uric acid in blood, are going to be used. Another is to increase the concentration of penicillin, and actually is going to be a kidney protector when you are using some antivirals. Sidofovir. Remember? Okay. So it's recorded, so that's why I want you to listen and stop and review it, please. Okay? All right, so that is the methotrexate. Can you tell me 10 minutes before, please, or 5 minutes before before 2? Okay.
Yeah, no problem.
What time is it? I don't have no.
1:45 right now.
Oh, okay. We got it. Okay. All right. So nursing considerations to monitor the hematopoietic function. Do not get any vaccination without healthcare provider approval because of the low levels of white cells. Okay, especially if there is some attenuated virus or attenuated bacteria can produce some problem. So be careful with the vaccinations. Now, let's talk about the beam blasting and the beam crysting, and basically we almost done with this. So because I'm going to make it directly and easy how to remember this. Okay? So those are the mitotic inhibitors, just to mention, because I don't want you to remember. They're not going to ask you, is this mitotic inhibitor? This is whatever, antimetabolic? No, they're not going to ask you that. They're going to go basically in this lecture about the names, side effects, and nursing considerations. You okay?
Okay.
Okay. All right, so we have the beam blasting. The beam blasting is, remember, is the strongest myelosuppression effect. Which is myelosuppression? Who can tell me what is myelosuppression? What is myelosuppression? Right, homework.
Would that be muscle weakness?
No, it said myo is muscle, but this is myelo. You know what? I 100% prefer that, I mean, the attitude to participate rather than the best answer. I really highly appreciate. Okay, so that is how we learn. That's my point. And really, thank you so much. If you make mistakes, I make mistakes too. Yeah, I just make a mistake in just a few moments, and actually, that is a way to learn. And I really thank you for that. All right, myelosuppression means myelo means the red bone marrow. Red bone marrow. So in other words, they are going to, is the same to say bone marrow suppression, the BMS. Myelosuppression is exactly the same to say BMS, bone marrow suppression. You okay with that?
Yes.
Okay. Now, talking about these names, beam blasting. Beam blasting is the strongest from all these antineoplastic. There's another chapter, chapter 1, chapter 2, this is chapter 1. From all the antineoplastic, this is the worst that can produce BMS, myelosuppression, the strong myelosuppression. How to remember that? Just remember the word blast. Beam blasting is a blast. Beam blasting is a blast. It's a blast. It's an explosion. It's a blast of that can lead into BMS, myelosuppression. You okay with that?
Yes.
The other one is the beam. Can you see beam, 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 beam blasting, beam, 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 Christine? Somebody's Christine here? Hopefully no. Somebody's called Christine? No? Okay, good. Is the most toxic. No, it's the most neurotoxic. I think instead to say toxic, I will say neurotoxic. Neurotoxic. Is the most neurotoxic. Neurotoxic means it can produce numbness, paresthesia, neuritis. And how you remember that? Christine is the most toxic. Neurotoxic. It's very nervous. Being Christine is the most neurotoxic. We okay with that?
Yes.
Okay. Taxanes are going to be just mentioned. The side effects are going to be nausea, vomiting, stomatitis, BMS. Is everything shared. So what they're going to ask you here in this this lecture is about what is the most of everything. Okay? All right. Now, let's talk about the topotecan and irinotecan. Irinotecan is the one who produces most diarrhea, most severe diarrhea. Most severe diarrhea is the irinotecan. Diarrhea irinotecan. How to remember that? Irinotecan, I run to the can. Okay, we got it?
Yeah.
Yes.
Okay. Then we have another term that has been used in some exams is the mucositis. Mucositis means painful inflammation and ulceration of the mucous membrane lining of the GI tract. So any lesion that produces an ulceration, a decontinuation of the lining of whatever from the mouth to the anus, that is called mucositis. So mucositis is the inflammation of the mucus in any part of the GI tract. For example, we have this, we was talking here, the stomatitis, that would be a mucositis. Okay?
Okay.
Oh, by the way, I forgot to mention here this. The vinblastine and vincristine can produce lung toxicity. Lung toxicity. Please, blastine and cristine, lung toxicity. Besides that, the vinblastine is the strongest myelosuppression and the vincristine is the most neurotoxic, these two, they can produce lung toxicity. What does it mean, lung toxicity? Lung toxicity means fibrosis of the lung. That means lung toxicity. What does it mean, fibrosis of the lung? Means the replacement of scar tissue in the lung. Okay?
Yes.
And we have another antineoplastic just going to mention. So we have this asparaginase, pegasparaginase, asparaginase. So this is the asparginate, that is an amino acid that is going to need it in order to be part of the cell division. And this enzyme is going to block that amino acid. So the cell division will not happen, just to mention. I'm not going to picking on this. All right, so we have here, in general, antineoplastic, we have fear and anxiety. Fear, anxiety. Anxiety, obviously, is the fear for the unknown. You cannot tell what is going to be the outcome, right? Insomnia. The patient is sleeping or not, so you can tell in the morning the patient is sleeping more than 8 or 9 o'clock in the morning. Is because most likely the patient was not able to sleep at night. Okay, so we have depression. Depression is not here yet, but depression, how you can tell the patient is depressed. You're going to ask, tell me, will you please tell me, are you depressed? You're not going to ask that because the patient doesn't know what is going on, right? What is depression or not. So the clue that is giving you that is to ask the patient, how do you sleep yesterday? If the patient is telling you, I couldn't sleep, that means that most likely the patient are entering into anxiety and or depression. We okay with that? So everything away from normal routine of what do you have a routine? You sleep, right? Normally, right? So and you wake up relatively rest, right? But these patients are going, you can recognize that. How do you sleep? Very important question. So that is giving a clue that the patient is depressed or anxious. Okay? All right, so risk for impaired skin integrity, alopecia, rash, screen, risk for constipation, diarrhea. After episodes of diarrhea are coming some episodes of constipation. But the most common first line situation, side effect will be diarrhea. Fatigue, why? Because you are losing red blood cells. right? So you have anemia, less transportation of oxygen, whatever physical activity you have, you're going to feel tired. Risk for infections. Why? Because the white cells. Risk for altered oral mucous membranes, because the cell division of these cells who reproduce very fast. Risk for altered oral is the same thing. Acute pain. Yeah, acute pain. For example, the sensation for cold, right? For a spicy food, hot food. So the patient is going to be very sensitive on that. Altered nutrition. Obviously, you can actually, your habit to eat, you don't want to eat because everything is painful, everything is bothering you, you cannot stand it. Fluid balance deficit. So always need to give a lot of fluid to the patient in order to prevent cystitis. Because if the chemotherapy are going to be eliminated and they are going to stay for more period than necessary in the urinary bladder, the lining is in contact with that waste product, and you want to urinate more often to get rid of that. Otherwise, produce a cystitis. Anticipating grading. So patient education, when we finish, when you have a patient education, this is MedSearch 1, I guess. You're going to say, the patient know that is having cancer. So they enter into the phase of denial. Remember those classes? Remember?
Yeah.
Yes.
Tell me, when is, and you need to have patient education. So obviously, if you're going to come to the patient education in that emotional state, it's not going to happen anything good, right? The patient is not listening, the patient will not understand, he doesn't care at all. So that is the denial process. The question is, when do you start giving patient education? When is what you do or what you do in order to start patient education?
Would it be during the acceptance stage?
How you recognize that? This is a practical thing, huh? You're going to recognize that when the patient is telling you, what was the medication you was talking about? When the doctor is going to come to see me? Or when is going to be that procedure? So that is telling you that the patient is showing some interest already. That showing some interest, of course, you're not going to wait that moment and give all the buzz of information. You need to dosify the information. You need to have many sessions with the patient that bit by bit, as much the patient is going to able to collect information, you will be sure that the patient is receiving and apply the information you're giving to her. Okay?
Okay.
Okay.
Okay, so thank you so much. That's it for today. I hope you enjoyed the class. Tell me yes, lie to me. No, I don't.
Yes, we enjoyed it.
Okay. All right. Okay, muchas gracias. I will see you when? Next when? Friday.
Okay, thank you, Dr. G.
Yeah, don't go. By the way, you did all. Oh my God, somebody left. Everybody did the midterm self-evaluation.
I'm gonna go do it right now.
Please.
I'm gonna
Just
do it
help
right
me
now.
with that, please. Okay, help me with that, please. Okay, have a good night. Thank you.
Thank you. Bye.
Bye.